Hey, a tweet from this morning where I said the hands should be trilingual. And it's an interesting concept. I'll tell you where it came from. It's obviously something that I've thought about, where if you know multiple techniques, and you absolutely have to, I think it's absurd to suggest that one manual therapy technique is all you need. I don't know how that's possible, or even one model, a concept of how human systems respond to stress is even possible. That would assume that your model or your therapy solves every single problem you'll ever encounter, which is, I pretty much suggest that would be absurd. That being said, I slept before we came down here to Puerto Rico. Oh, by the way, I'm not sure other people know, behind me is Puerto Rico, pero yo puedo hablar. Aquí mucha gente puede decir inglés sin acento. They talk pretty good here, so there's not much that I need to translate. A lot of my friends, usually is females. Ella se habla de lo que yo puedo hablar como gringo, pero la gente de aquí, muy bien. Ellos dicen que habla bien. All right, so we're in Puerto Rico. I was getting some treatment because when I fell on this side. It's no big deal. It's probably more embarrassing if someone saw me, but ultimately my neck was bugging me. So one of our therapists for this trip, Mary Lancelot, is here. And by the way, Mary is our head trainer with the cadet team, and I'm just really thrilled. Obviously, travel during this period of time with the nonsense is a challenge for everybody. And I was able to come. Some other folks weren't able to come. Mary was able to come, and I'm really glad that the therapists for our younger teams are able to be a part of what we're doing with the first team. They see where the systems are being originated. They see the systems happening because we want our athletes in Canada basketball to be going through this system, so that when they do get to the first team and when they do get to Division I in the NBA, they're able to feel very good about what should they be doing, what shouldn't they be doing, but also being very respectful to the different models that they're in. So I'm really glad that Mary is here and being able to be a part of what we're doing. She's treating me, so that's the most important thing here. And we're talking, and she's doing her thing as a trained osteopath. As we know, in America, we don't really have a significant amount of true osteopaths. We've got the DOs, but they're more like MDs by license. And then individuals that do practice osteopathic techniques probably can't even say they're practicing osteopathy in a legal sense. Anyway, what I was saying is, as she was treating me, it was a very gentle technique, and I'm used to some things that are more aggressive. And as we were connecting, I said, so when you feel, my opinion is, no matter what the techniques that you're using, your hands have to be able to convert or translate what the tissue or what the system is telling you to your brain, and then back to your hands, so you can change or manipulate your own touch, where in essence all you're doing is impacting the neurology of different structures, and different techniques are going to be better at some versus the other. So when I said that your hands should be trilingual, we should be able to impact soft tissue with what we think is a soft tissue technique, which can accomplish a number of different things based on whether we are attempting to change the perception of pain or attempting to put the system in a better place, a more efficient place to acquire new motor skills. We should be able to translate the language of trigger points. I'll never forget teaching a seminar at Joel Proskowitz's facility in London several years ago, and I really am disappointed, and I'm sure it'll be in the comments. I forget his name, but it's somebody connected with quite a bit when travel was a little bit more fluid. And there's a famous therapist who says trigger points don't exist, and happens to be from the UK. And I happen to find that absurd. If I push here and it hurts over here, what is that then? I said, what would your boy call that? And they said they'd call well, he'd call that a neurological phenomenon. Fine. I call it a trigger point. A lot of other really intelligent people way more intelligent than me, call it a trigger point. You call it a neurological phenomenon, and how about we all just call it a draw? That is a different feel when we're looking for what we're told is a taut band. And you can only tell what a taut band is by touching in a particular way, and then your brain recognizes, yes, that's what it is. So the psychomotor nature of learning the language of trigger points is very, very important. And then what you would do to, if you're using your hands, create ischemia in that relative area of tissue, which would then be evaluated not by the quality of the tissue and the taut band, but if there was pain in the familiar referral pattern. So if we're going to say there's a trigger point in the infraspinatus, of which there's 3, then we're going to try to feel. And if someone has anterior shoulder pain, it might be one of the first places you go to start to work a little bit, because if it is a trigger point, well then looking at other pathoanatomical models probably isn't going to be very, very successful. That's the person that has significant shoulder pain, weakness on your special orthopedic tests, but then on MRI or X-ray, there's absolutely nothing to support that this is something pathoanatomical. So we look at that, but now when you feel, okay, that's an area. Now, is that a taut band? Hey, do you feel what you feel? Not do you feel, yeah, it might feel uncomfortable on my thumbs or my hands, but do you feel your pain? And that's very, very important with a number of different manual therapy techniques. Sometimes they're not very comfortable, but that is a normal and a very localized response. So now you do believe it's a taut band, and then how much heat are you going to bring to that party? What are you going to do? In your brain and your hands have to constantly be navigating and constantly translating what you feel in your hands. And this is a very interesting concept, but it's not as abstract as it may appear, because how do you know? How do you know when it's enough? Well, certainly we want to judge in the trigger point language. Does your shoulder hurt anymore? What special tests did you think were under standard, whether they were strength tests or motion tests? Let's see what we got afterwards. And then lastly, we got to think about a joint technique, a joint language. So obviously there's a lot of techniques that are joint related, joint mobilization or joint manipulation. Now, in my opinion, I don't think there's any significant level of moving a joint. One of the things that Mary and I were talking about was, look, if a joint is out of place, a lot of times patients will say this to us. Well, I went to so-and-so and they said that my hip is out, or I just go to my whatever clinician and they just put my whatever L5, S1 back in. I said, listen, I said, Mary, I don't always say this to people. You have to read the situation, you have to read personalities. But when I do respond with that, I would say that, look, I'm going to tell you the truth. I'm very glad that you can get relief from a certain technique. And if that's all you need, we'll just do that technique. And if that's what you're looking for, maybe we can help you in further ways, because those other ways really aren't going to work if you're in pain. More importantly, if your hip was out, I'm pretty sure I'm not the healthcare provider that you're talking to at that time. You're probably in the emergency room, and you might not be talking at all because they just packed you full of Demerol for the amount of pain that a dislocated hip would be yielding. So I think what we learned from Mulligan is the term positional fault, where there's nothing pathological about the anatomical position of the joint. However, the perception or the level of decentration of that joint is what the body perceives as uncomfortable or painful, which would really be the only explanation as to why joint mobilizations or high velocity techniques work. There's nothing, because someone else might have a different position of, let's say, their shoulder in the glenoid, and there's nothing evil. There's no, if 5 people don't have pain and 5 people do, it can't be pathoanatomical, but it's more of a perception. And why one person and not the other, that's a whole gamut of information that we usually don't even know, particularly when you're seeing someone for the first time. But certainly techniques that we're thinking are affecting the joint. If you're mobilizing a wrist, is now translating what am I supposed to feel, and then what does my brain tell me that I feel that I should do more of, less of, but then what is the objective measure that says that what we did was desirable? Because ultimately, as a therapist using manual therapy, I think you can prove two things, and no more. I think you can prove what you thought you were doing based on what you were taught. So if you are taught that you're moving things in a convex concave, if you taught that you are putting something back into place, if you're taught that you're breaking an adhesion, that's where this starts. But honestly, that's probably a very, very kindergarten level of thought process. That's where I'm at. I don't think it's wrong for somebody to think that. I think it's wrong for somebody to beat their hand and tell you that's exactly what's happening, because I don't think it is. You can prove what you tried to do based on what you were taught, and number two, you can prove that something very desirable happened. If the person has less pain or moves differently, did you do it by breaking an adhesion? Probably not. But did you do something very, very good? You absolutely did. And you shouldn't have to apologize to using a technique that actually did something really, really good. Now, what I think is probably much closer to the problem is someone using one of these neurological techniques. They're not affecting the frank structure of the tissue when it's a quick hit. Manual therapy needs to be held a significant period of time, over a significant period of time as well, to actually make changes in the direction of the collagenous tubules in the connective tissue. That's not what I'm talking about. That's just another way of using time under tension. I'm looking at affecting the nervous system very, very quickly so that you can move on and be more successful in your motor skill acquisition, which is probably what led to the perception of pain in the first place, which is what led them into your care, which is what leading you to get your hands on them and start to translate what you feel so you can create a better environment for them to train. Whatever training means, obviously I think it should be physiological, but it's the inequipped physiological fitness that leads to the neurological compromise. And to get in that first start is really using a set of hands that can translate to your brain what it is, what is the structure that you're looking to affect, and how do you affect it. So that's what that means in terms of being trilingual. If there's other techniques, Mary brought up viscera. That's not in my training. I've learned some global positional stretches, global postural stretches rather, that affect the viscera, but that's not my bag. I remember being treated by Sam, and he's poking around up here in the upper right quadrant. He says, "Oh, your liver's tight." I'm like, "What?" And you know what? I don't care if somebody were to say that's ridiculous, because first of all, Sam Gibbs is absolutely the best therapist on earth as far as I'm concerned. And if he says my liver's tight and he can make me feel better so that I can do other things better, then I'm not. It's not even a. It's beyond not worth discussing. Just because you don't know something that someone else knows, or you don't believe something someone else believes, it doesn't mean they can't help you. It just means it's not part of what type of clinician you are. So some things to keep in mind. Trilingual hands. Anybody seen a leprechaun? Say yeah.